Hi, my name is Zheng, and I spent the summer gathering stakeholder perspectives for North Carolina's COVID-19 Support Services Program, or SSP. From September 2020 to April 2021, the North Carolina Department of Health and Human Services subcontracted with various community organizations and health systems across 29 counties to provide financial relief, home-delivered meals and medications, medical transportation, and COVID-19 supplies such as hand sanitizer and face masks to over 42,000 households that need to isolate or quarantine due to receiving a positive COVID-19 test or being exposed to someone with a positive test result. Community health workers, or CHWs, were also deployed across 55 counties, addressing the surge in pandemic-related social needs by making over 121,000 referrals to local resources. The state also rolled out NC Care 360, a new online platform which allowed CHWs to make electronic referrals to local service providers. With the state moving towards integrating health and social services via the Healthy Opportunities pilots, we wanted to use the COVID-19 Support Services Program as an opportunity to better guide implementation of the pilots. First, expert stakeholder meetings were held to discuss the SSP and the pilots in the context of the broader movement towards using value-based care to address social determinants of health. These initial convenings shaped future interviews, helping us think through what questions would be most useful to ask in understanding implementation challenges, best practices, and lessons learned. Various stakeholders at all levels of SSP were then interviewed, and common themes were compiled and synthesized. In the interviews we have conducted so far, 5 overarching topics have emerged: capacity of community-based organizations, the role of CHWs, communication channels, community partnerships, as well as using NC Care 360 to manage referrals and collect data. The pandemic led to unpredictable surges in demand for social services. As such, community-based organizations with already limited capacity and financial resources had challenges fulfilling surges in demand. In response, CBOs had to implement various volume management strategies, such as stricter eligibility checks and maintaining waitlists. The role of community health workers in SSP was also not incredibly well defined. With the state moving towards greater standardization of the training and certification of CHWs, they could eventually help reduce caseload amongst licensed care professionals such as social workers in future health and social care initiatives. Another challenge stakeholders faced was a lack of set communication channels between frontline workers, program administration, and the state. Due to the changing nature of the pandemic, organizations would often receive a directive from NCDHHS and have very little time to actually implement it. As a result, some vendors held regular meetings between various stakeholders to gather feedback and ensure that efforts were aligned across different levels of the program. To overcome historic mistrust and increase program reach amongst marginalized groups, community engagement in SSP was an all-hands-on-deck effort. Vendors made formal and informal partnerships with a variety of community quarterbacks, such as faith-based organizations, food pantries, and schools, deliberately prioritizing partnerships with organizations led by members of historically marginalized populations. Organizations with canvassing experience were also employed, leading to less traditional collaborations with census advocacy and voter registration groups. Finally, deployment of NC Care 360 to manage resource referrals and as an electronic data hub was hindered by long queues for support and an English-only rollout. Lack of broadband infrastructure also made using the platform difficult in rural communities, leading to some organizations to use mobile technology such as tablets with portable hotspots and small scanners to send in paperwork. Looking ahead to the Healthy Opportunities pilots, it's clear that NCDHHS has an abundance of opportunities to mobilize the infrastructure and partnerships built during the Support Services Program. With service delivery not slated to start until spring 2022, the department has time it lacked during the pandemic to adjust NC Care 360 and work through many of the challenges expressed by stakeholders in these interviews. However, there are numerous additional considerations that must be made to ensure that service delivery can be sustained and that periodic evaluations of the pilots can capture both the financial and human impact of such interventions. Ultimately, more systemic institutional changes beyond payment and delivery reform will be necessary to truly realize health equity. Thanks for listening. Before we go, I'd like to acknowledge the rest of the research team: Hannah Crook, Katie Huber, Will Blesser, and Rebecca Whitaker, as well as Rob Saunders, Jasmine Massant, and Michelle Lynn. Special thanks also to our internship program coordinators, Julia Johnson and Risha Bott, for making this work possible.